I couldn't, Doctor, send mail yesterday with the presentation because it was too big, and I think I tried to make it by the platform.
Yeah, we can try. Yeah, Veronica. Yeah, absolutely. And I also have the presentation of Gisella and Kinka.
Oh, Doctor, I know how to view presentation on the.
Perfect, Justina. Perfect. It's really a pleasure to share with you and talking about your patient. Kamil.
Wojtek.
Wojtek is
Beata.
already with us, yeah.
Buongiorno.
Ciao, buongiorno.
Ciao.
We are six. Who is missing? I think that there are someone who will not join with us. We'll wait.
Margarita, she will be missed today because she have some another course in this day, and she told this to Mr. Darek. And I know about her. I don't know the
Perfect. Beata, ciao.
Hey.
Morning.
Morning.
Hey.
And in a few weeks, we are seeing again for your thesis.
Yes.
Who is afraid about thesis?
Yes.
I think that everyone.
No.
Everyone, I think. It's everyone.
It's not to be afraid about thesis, really. It's
really.
Yeah. No, really. No. The very important thing is start a fight with the people of the commission. If they ask you something, just think about and try to give an answer. But it's just this one. It's because you have to follow your presentation. And sometimes last year there was a colleague that every presentation start to see about the literature. And of course, if you see the literature, you can find the opposite of what we are talking about. But you are not to be the paladin. You are not the knight against something. Just to explain your thesis. It's not to fight again Kinga, Kamil, Gisella. So just follow your thesis and thinks that there is no one that want to make problems, emotive problems when you are talking. So 7, okay. Who's missing? No, Paula. Paula has to join with us today. Do you know anything about her?
We don't know.
Okay.
Magda.
Magda today is not joined, isn't it, Gisella? You told me about Magda, isn't it?
No, Margarita.
About Margarita.
Margarita, okay. So Magda and Paula, we wait just a couple of minutes more and then we start. I realized that during online lesson, it's very, very hard for everyone, for you that listen, for me that are speaking. So we are trying to make a small break each hour, if you are okay. also 5 minutes break, but just to take a relax. So after 1 hour, just say something, and so at the first slide as possible, we'll stop for 5 minutes. Okay?
Okay.
You see the screen? The
Yes.
slide?
Yes, 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 yes.
Okay. Someone is coming.
Mama, bye. Zaraz włączę.
Paulina. Ciao Paulina.
Ciao, buongiorno.
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 Oh, eccola. Ciao. Buongiorno. So I think we can start. You have the slide, isn't it?
Yes, we can see.
Okay. So yesterday we started to talk about bonding and the importance of bonding in each orthodontic technique. And you know that bonding, you can have two different types of bonding, direct bonding and indirect bonding. Direct bonding, it's sometimes it's the easiest way to bond a patient. We don't need extra impression, and we have a direct vision, so we can control the surplus of composite, and we can have the last check before to bond the brackets in our best position. But with direct bonding, of course, we have a problem of vision because we have a very small vision due to the labial retractor model that we are using. There are a lot of labial retractor model, and I ask you about choose your right labial retractor model. One of the wrong way to have a direct bonding is to use a different type of labial retractor model. When you find your best labial retractor model, use always the same labial retractor models. There are a lot of different labial retractor models on the market. Here you see 3 of this labial retractor model. I don't like this kind of labial retractor model at all because they have a good vision for the frontal area of my patient until cuspid, first bicuspid, but it's very, very hard for me to have a vision of the posterior area. And for this reason, I prefer this kind of retractor in which you see on the right of the picture, it's possible to add a more extra retraction of the labial, just pulling back with our fingers. And you see here that I can arrive to the first molar. Another labial retractor that's very, very interesting, it's the NOLA, N-O-L-A retractor that allow us to have also a suction of the saliva. And indirect bonding have some advantage. The first advantage that the clinician explain us is less chair time needed. you see that particularly in American orthodontic clinic, less chair time, it's something that clinician looks very much, because less time chair, it means more patient that I can see in that chair, and so less money for the office, and more money that get in the office, because you know that every hour's office have some money to spend. It's the hour cost of our office. Of course, it's less chair time needed, and it's something very good. But for me, the best and indirect bonding advantage is the better bracket position, particularly in the posterior area. Another advantage is that we can delegate also to dental chair assistant, if it's possible to in your countries to delegate the bonding to dental chair assistant. You can delegate the bonding to the patient with the indirect bonding. But with indirect bonding, we have a couple of disadvantages. One is that usually we need an extra impression, and another disadvantage that very often we have too much composite surplus to remove. When you have indirect bonding, you start working without the patient. I don't know if you are using indirect bonding or direct bonding, but if you are not using indirect bonding, I advise you to try to use for some patient, because doing indirect bonding and prepare the indirect bonding, it's a good way to have a better also direct bonding. With the indirect bonding, you see here that we can have the model the cast model in our hands, so we can rotate the model and see all the teeth surface, vestibular, occlusal, or palatal, and lingual, and so it's easier to put the brackets exactly where you need to put the brackets on. And you see that with a pencil, I can mark the long axis, and then I can mark the horizontal axis for each teeth. And of course, here on the palatal view, you see that I marked also my point for each teeth, just to have the brackets just in the middle, mesiodistally position. And you have to repeat this for every single teeth. There is a good way to prepare an indirect bonding, and this is the prescription-based precision of indirect bonding of Calange. I will give you this article through Direct, and I recommend you to read carefully, because this is a very good article. Sometimes you can ask to your laboratory to prepare your indirect bonding. Anyway, you receive or you prepare indirect bonding, and you see here that it's at that point, just with flow composite, it's very easy to bond the brackets on your patient, and it took 10 to 15 minutes to bond both arches of your patient. Of course, with indirect bonding, you can have sometimes some a mistake. Here in this patient, I've done indirect bonding, and of course, it wasn't possible to bond on the central lower incisors, a bracket in the right position. Oh, wait, Camille. Okay. Or in this second premolar, that I had a big surplus of composite on the second upper premolars. Today, with the intraoral scanner, it's easier to make a indirect bonding, because of course you can scan the arches of your patient, and with one single scan, with one single model, virtual model, I can do all the model that I need and work with this model. But there are also some software like Ortho Analyzer that permit us to have an indirect bonding, and so you decide which kind of brackets you are using in your practice. These are active brackets in this image, and you can decide to put the brackets just on the tooth in the right position of our virtual cast of the patient. And when I finished to have the right position for all my brackets, then I can print my model with the brackets on, or I can print directly the aligner to have the model to use for my indirect bonding. Probably this will be the future of indirect bonding, because it's something that it's faster, and it's virtual, like with what we are doing with software, with Invisalign or Insignia or Incognito, all the other software. You see here, I just receive and then put my brackets on in the right spot, and then I can bond the patient. When you start using indirect bonding, it's better to bond few brackets altogether, not all the arches, or not all the brackets of the arch together, because it's easiest to bond 3-4 brackets each time. If you are choosing direct bonding, it's very, very important to, okay. When you are choosing direct bonding, it's very, very important to have the right time in your agenda. That's very, very important for me. We'll talk about this when we'll talk about management of the orthodontic office, but you have to think about and choose what you prefer. In my practice, I prefer to do some operation only in a certain time. This is my agenda. You see that in the morning, the first patient that I have, her name is Elena, and I brought down bracket, sup and if, upper and lower, and I reserve for her 1.5 hours. It means that for 1.5 hours, I just bond the brackets in this girl, and because I don't want to be in a hurry doing certain operation. And in different hours, you see in the afternoon that there are only control or some impression to take, or changing wire, changing removable appliance, checking all them. But in certain hours, I do only some particular operation. Why? Because I saw that every time that I permit to a patient to come when he wants, so when she wants, like in the afternoon, 1.5 hours in the afternoon for my practice, it took like 4, 5, 6 patients in the same time. And so you know that with orthodontist patient, we see a lot of children and young patients, and they usually go in school in the morning. So when you need to do something that it takes time, decide to reserve the right time in your office. And bonding for me, it's one of these operation. So if the patient arrive, I reserve to her 1.5 hour, and the patient arrive half an hour or 45 minutes later, I just explain to the patient that I will bond just one arch, or I got to move the appointment, because sometimes when there is a patient that arrive late, you risk to don't do the right work on your patient that is coming late, but also in the next patient in which you'll start late too. So that's something that after a while your patient start to use to understand and arrive at the right time. Always with a direct or indirect bonding, you need to have a panoramic X-ray in front of you, because usually you want a panoramic X-ray to control and to check all the roots of your teeth. And that's very, very important, because the roots of the teeth are not bad positioned in the same way. So I can have like in this panoramic X-ray, the first lower bicuspid on the left side has a mesial-distal inclination worse than on the right side. And of course you have to check and decide which is the best position for that the brackets to bond the brackets. Another thing that it's very, very important is to organize during the bonding the position of all the braces. You see here, this is a picture in Siena in which the our colleague just prepared a paper in which he wrote down the number of the teeth, and so she will position every single brackets ready to be bond in the mouth of the patient. There is a very big difference between altimeter. There are a lot of type. You can use the altimeter that you prefer. As I told you for labial retractor, when you find the right altimeter, use always the same altimeter, because it's there are some difference from one to another altimeter. Of course, not in the measure that it's marked on the altimeter, but in the way you are using them. And for me, that's very, very important, because during the master, I explained to the colleague that master, it's a good moment in which you can try different instruments from different colleagues, because it's the same for me with the plier. There are a lot of same plier with the name, but they work completely different in our hands. And it's very, very important, like with the chin back. In my office, I have 6 different types of chin back, but I have just one of this chin back that works properly in my hands. And this is something that was very, very important during the 60s and the 70s, because you have to imagine that in Tucson, where there is the Tweed Foundation, sorry, there is someone, no, okay. In Tucson, where there is the Tweed Foundation, there was a person who prepared handmade pliers for the orthodontics. It means that he prepared pliers just for that fit just your hands. And it's very, very important, because pliers, altimeter it's our tools, and it's very, very important to use the best tool for your hands. This is a direct bonding in my office, and just preparing, and you see here, just position the brackets, having a view, also an indirect view through the mirror, and just removing the surplus of composite, and check again the with my altimeter the position of the brackets. These are just few of different brackets positioner altimeter. I prefer this kind of altimeter that can have the head that you can turn of 45 to 90 degree, and so you can use very, very easy also in the posterior area. Remember that when you are taking a measurement of with your altimeter, you have to be perpendicular to the tooth. Sometimes we are not so perpendicular, but you can have different position of the brackets. You see, just moving your altimeter just a little bit up or a little bit low, you go to have a difference of position of your brackets. So direct bonding for me, it takes almost 1 hour just to bond the brackets for this reason. The best position you find for your brackets and best finishing of your treatment you will have. There are also some pliers that can help you for the posterior area, particularly in the second molar. If you are not using them, you can try to use them. They are very, very clever plier, and they are very, very easy to use, and they can help you on the first and on the second molar brackets. To have a dry area of the posterior area, I use also this little pad from Neo Dries. If you are not, if you don't know them, you can try. They help you a lot on the second molar, particularly on the second molar. And another thing that I use usually in my office, it's a mirror suction. It's a mirror suction. You see here, it's a mirror, so you can have an extra. You can put the labial area far from your teeth, and have also a suction mode. And so it helps you to have a dry area on the posterior part of the teeth. As I told you, dental cast not only in front of you and in your hands during the indirect bonding, but I want to have dental cast also on my table when I do direct bonding. And you see here just working direct bonding on this patient. I have panoramic X-ray on my screen, and I have a dental cast on my table, because sometimes, particularly for the bicuspid, you need to have a look on the dental cast to understand better which is the best position for that brackets on that tooth. Sometimes we need to bond brackets on worn out incisal edge or fractured teeth. And in this case, we have to decide to rebuild the teeth, or we have to decide to create an extrusion to balance the part of the crown that you want extruded. And some colleagues do this before orthodontic, and other colleagues do after orthodontic. You can do whatever you prefer. Of course, if you are doing after orthodontic, or you have more play to decide after that you finish to move the teeth. If you are doing before orthodontic treatment, sometimes you need to reshape the tooth after orthodontic treatment. It's up to you, but it's something that you have to consider and to decide, like on the left part of the screen, on the upper first central incisors, to extrude these central incisors of ½ millimeter or not. Rebonding time. Before the Demon technique in my office, I'm not familiar with rebonding. I just in that period I used bioprogressive technique and Janelli technique, and I'm not familiar with rebonding because no one explained me that rebonding can be useful for our orthodontic treatment. Starting with Demon technique, Demon system, I realized the importance of rebonding appointment. Rebonding appointment, it's an appointment in which you want to just to take time in your orthodontic treatment. You need to stop. You need to think again about how is going your orthodontic treatment. There is something that I can change to have a better treatment or not. Usually, you know what's happening in our office. We bond the patient, we start the treatment, we reserve to our patient certain time, and we have some minutes, 10 minutes, 15 minutes, 20 minutes to see the patient at every check in your office. And then you have someone else who is coming in the office, and you have to make a new check to a new patient. So most of the time, in most of our patients, we don't have the time to stop and think about. And you have to reserve the time in your office for your mind sometimes, because rebonding, it's an appointment that I do in all my patients with braces on. But if I have a patient that is not going on the right way of the orthodontic treatment, I took like a rebonding appointment, an appointment in which I have to stop, in which I want to take out the dental cast. I want to see all the picture of all the appointments and just stop and think about what's going on. If it's possible to find where it was a mistake, my mistake, patient mistake, patient cooperation, biological response of my orthodontic treatment. And in that appointment, I want to feel free to change completely my treatment, because you know that it's impossible that all our treatment goes in the best way that as possible. During rebonding appointment, we need to take a new panoramic X-ray. And this is the usual protocols of Demon system, but like other orthodontic techniques protocols. We start with the light arch wire, and then we go with stronger arch wire. And in this patient, I just use build-ups on the first molar. I just put braces on all the teeth except on this deciduous tooth on the lateral incisors, and I'll start with very light arch wire, 0.13 copper night eye, upper and lower. I go through my, after 10 weeks, I go through my second arch, around arch wire, in which I put a coil to start to open the right space for the upper lateral left incisors. You see that the two arch wire, I decided to put a 0.14 copper night eye on the upper arch wire and 0.16 on the lower arch wire, and then I go through a rectangular arch wire. So in the second phase, and this is the occlusal view of the movement, and you see how it's changing the arch of my patient to rebuild the arch of my patient until I arrive to the rectangular arch wire. We do, after this, we are after the second phase, between the second phase and the third phase of our patient, we do the panoramic X-ray, usually after my second rectangular arch wire. And that's very important. Remember that the second rectangular arch wire, most of the time it's 18/25. And we use the first rectangular arch wire between 8 to 10 weeks of treatment. The second rectangular arch wire, 18/25, we use it for between 6 to 8 weeks. And then we do the rebonding appointment. It's very important. Remember, when you are using 18/25, to don't stay on this arch wire too many weeks, because in particular on the lower arch, using 18/25 demon form copper night eye, sometimes you can create an hyper expansion of the lower arch, and you can create molar in a cross position. So watch out for the use of the 18/25 arch wire. I always use them, but if I use them for too many weeks on the lower arch, I want to check them and to check the first and second molar position, because usually you see the patient and you are not checking enough on the first and second molar position, and with this kind of archwire you need to check them carefully. Rebonding time, I need to analyze very carefully this position for the brackets. And also now, after several years that I'm doing rebonding appointments in my patient, I open this slide and I want to check all these points in the mouth of my patient. Once again, the rebonding time has, in my office, the right time. Usually I take for rebonding time 1 hour, because I need to take picture of my patient. Usually I take picture of the face, picture of the smile, picture intraoral picture, and the dental chair assistant put the picture directly in my software, because I want to see the picture on my screen. Then I took the panoramic X-ray in my office, and then I just sit down on the dental chair and start to analyze everything as much as possible. When you analyze at rebonding time, you analyze your patient. Get used to observe teeth for more angulation as possible. Usually you arrive at the dental chair, patient is on the dental chair, and we used to see the patient just on a very limited area of the face of our patient. It's the right side, right middle side of our patient. But at least at rebonding time, just used to look your patient front. We want to see the patient from a front view, from a right lateral view, from a left lateral view, from an occlusal view. So go around your patient. See your patient standing up and ask the patient to smile. It's very, very important to use to analyze your patient in a different way as usual, as what we are doing during the check. And to analyze the patient from different angulation, we need also indirect vision. You see that in that indirect vision, I use also a very big mirror that helped me a lot to have an indirect vision of my patient. Remember that looking something from different way, from different view, can change completely what we are looking. And this picture explains this idea very, very well. You see here that there is just a solid, and if we see this solid from two different views, it can appear like a square solid or a circle solid. And think about every time that you take time to see your patient, to see the bracket placement and analyze carefully. This is the reason why I bought this kind of big mirror. When you see a tooth with an indirect view, with a small, more normal mirror, you just see two teeth together. with a bigger mirror, I can see 3, 4 teeth together. And sometimes I prefer to have an indirect view with an occlusal mirror for intraoral photography. This is why I want to see the also have a complete and more large view of the occlusal view of my patient. It's not that I know that it's impossible for me to find every mistake at each rebonding appointment. In my normal works, it's impossible, but I try to analyze and to find all the mistake or the change that can help me to have better treatment of my patient. Remember to analyze the smile design. And remember, when you are analyze the smile design, to have the right view of our patient, not in the dental chair, because usually you see the patient in the dental chair and you are on a upper level view of our patient. When you see something, it's like when you take a picture. One of the first rule that you take if you are going to take a photography course, usually the instructor says, when you take a picture, you have to go where the subject lives. If I need to take a picture of a small dog, I go down to the same level of my dog with my camera, because I want that the camera has to be in a perpendicular position with the subject. Same way when we are taking picture of our patient, usually in my office we have a dental chair assistant that take picture of my patients, and when I have dental chair assistant new, they of course they have start to make some mistake, but we are trying to do as best as possible. So when you have to observe the smile line of our patient, just say with the patient, just go with the patient, just stand up in front of you and stay at the same level with your head and your eyes, same level of our patient, because it changed completely from an upper or a lower view of the smile line area. Another things that I suggest to you is to have the picture of your patient during rebonding on the screen. The dental chair assistant prepared for me on the software the picture that she has taken of the rebonding appointment, and so I can check every single tooth in a bigger screen. And I recommend you to have the best screen to work with in the clinic area, because it's in the clinic area that we have to look carefully to every different problem that we have in our patient teeth. So again, I just took my picture, took my panoramic X-ray, and then I just start with taking care for every problem that a bracket position can have in my patient. First things that I see, I go to have a look to the root parallelism. And for every teeth, I just seen where is the problem of my root parallelism. And remember that rebonding some brackets, it not means that I'm a good orthodontist if I rebond 2 brackets instead of 15 brackets. You have to look carefully and remove and rebond all the brackets that you consider in not a proper position, not with the proper information of torque, not in a proper occlusal position. And in this panoramic X-ray, I just look to some roots position that are not correct for me, and I just seen all the teeth on a paper of the patient. Remember that sometimes there is a not congruence between the crown and root position, and you, in that case, you need to decide if to have a root parallelism or to have a better crown position. And usually we prefer to have a better crown position than a root parallelism for that tooth.
But doctor, I have a question about this these roots because of course for the patient and also for us like doctors, the most important is the crown, yes, how it looks in the mouth. And for example, for the patient, everything is correct. For us on the photo, everything is correct. And then I take the X-ray OPG and I see the roots in like this. And what the next? It is for example, the further problem about the rotation after the treatment, because sometimes I have the patient that everything looks great after the treatment. I debonding the appliance, and after a few months I see the patient and I see a little bit of rotation of some teeth, of some incisors, and maybe it is the problem because I don't have a great parallels of the root. But what in this situation, because when I change the brackets, then I change also the position of the crown, and I will be some rotation in the mouth. So I don't know how to handle it with this problem.
Yeah, it's a problem, but the problem of this is that, of course, when you have rotation, when you have you debond the patient and you have movement of the teeth, there are some consideration that you need to do. And so for me, during rebonding, root position, it's important. I need to have a best parallelism of the roots, but I need to put the crown in the correct position. Then what you're talking about, it's very, very variable, because you need to think about how it is the occlusion at the end of my treatment. Is it a good occlusion, bad occlusion? And of course, after 6 to 8 to 10 months after the bonding, it's necessary to take a OPG to have the last check of the teeth after the treatment. And other times there are some oral habits or some bruxism that works in the tooth of our patient. Other time it's what is the last movement I have done in the mouth of my patient, because most of the patient go to relapse with the last few movements that you are doing on the patient. for this reason, the leveling and alignment that we are doing on the first two phases have the right time during the third and the fourth phase to have a better retention, active retention with orthodontic fixed appliance. And then when I go with retention, with removal of appliance, it's easier to maintain that position, but relapse of certain movement, it's a problem of a lot of different factors. So if I see that after that I seen in this picture on this OPG 1, 2, 3, 4, 6, 8 brackets that I had to rebond, I need to go in the mouth of the patient and look carefully if the crown is in a good position, or if the crown moving the roots, it will have a bad position. Because if it will have a bad position, of course, you can probably have the best occlusion for the patient. So if we are talking about this, the crown has the wing on the roots, but on the rotation is a problem of different problems, and you have to consider not only the roots, Gisella. Okay.
Yes, okay.
So in this case, you see that the lateral right lower incisors with the roots with a not good position. No, it is the central. No, the lateral. I'm sorry. Lateral lower incisors with in a not good position. But if I see the picture, I like the position of this lateral incisors, lower incisors. So in this patient, I just leave the brackets in this position. Of course, this is a young patient. The problem is with adult patient, in which you have the incisal age not in a well condition, and so it's hard to see and understand what could be the best position for that patient. But in this case, you see the incisal age and the position of the crown is so quite good for me, and I didn't change the brackets on this tooth. Another things that we are going to consider is the gingival edge. Gingival edge, so it means that we have to consider if we can change something to have a better gingival edge, or at least that don't create a problem on gingival edge. On this patient, during the first two phases, I just create a movement on the dental arch, and you see here that the left lower cuspid start with different gingival edge than the right side, but at the rebonding appointment, I thought that I can try to don't make it worse, changing the value of the torque of the lower cuspid of the lower left cuspid. And so I just use a high torque, and I go through 19/425 stainless steel, 19/425 TMA, and I arrive into this position. Other things to consider is the incisional age. And of course, here there is a difference. And so we have to decide to rebond the brackets on the left lower lateral incisors to a more gingival position. It's you see that all these things are take a lot of time to consider all this particular position for every single tooth. Also here, different in incisional age, and there is a difference in the position of the brackets. Another things to control is the black triangle, and this is something that could happen in every technique, and it happens from the different shape of the lower incisors, particular, sometimes also on the upper incisors, the triangle shape of the crown of the lower and the upper incisors. And you know that sometimes you arrive at the end of your treatment and you debond your patient and you found this little black triangle. This is the patient just debonded to finish to remove the bond on this teeth. But this black triangle that became something anesthetic for the patient. And when you start with crowding, usually the patient at the beginning didn't see the, didn't appreciate the triangle shape of of his teeth. And so at rebonding time, it's a good appointment to check them, because you align and leveling all the teeth. And if you see or start to see black triangle, you can decide to have a little stripping on the upper part of the crown, or you can decide to have a reshape of the crown at the end of our treatment. It's up to what you are deciding with your patient, of course, and how much of stripping do you need to have a better contact of the lateral crown of the teeth. I think this is very useful, this this kind of guina that allow me to have a very light stripping between the teeth with no problem to the papilla. Of course, sometimes you can have only a stripping, a very, very light stripping with auricle stripping, or other times you need a burst, very, very teeny burst to have a different shape of your incisors. Of course, after this, you need to insert an elastic chain, usually an elastic chain with space. We are with Demon system, we are not using elastic chain without space until the last part of our treatment. So the last phase of our treatment in which we are using elastic chain. Of course, we have to consider also the in-out position of our teeth. In particular, watch out for the composite surplus on the base of our brackets. We check the tipping, rotation, things about the sometimes when you have very big rotation to overtreat the rotation. Rotation again on these first premolars. And of course, if you imagine here to rotate these premolars, it helps you to close this space. Every time you see that after the second phase, there are space between the teeth, think about if there is a mistake with the position of our brackets on the teeth. And then we have to reconsider the torque value of our teeth. It means that when we are thinking about the torque value of our teeth, you have to open again your patient chart and retake and remind about why you choose a certain value of torque in the patient. Sometimes, I told you that sometimes, particularly using early elastics, you can have that you can choose